and gentlemen, as you know, Dr. Firemilk has a very strong patient-first philosophy. And to help, and that patient-first philosophy is to help each and every one of you individually to achieve optimal health, optimal heart health, and trying to do this in the most non-invasive way. And that's not always easy, but that's always the goal. This is demonstrated by the testing that she orders. It's demonstrated by the personalized treatment plans that she puts together for you individually. And probably a really good example is the use of evidence-based nutraceuticals, supplements, whenever she can, and test those versus pharmaceuticals. So it's always the least invasive and the lifestyle side first. So we really appreciate that and how she does that. And our whole philosophy surrounds that patient first. Well, because of this patient first mentality and this patient first philosophy, she's very serious and secure with her referrals. It's very important to her. She doesn't just pick out referrals and hand them to people. They have to be trusted and earned. And one of the areas that's really important for us to do referrals with has to do with diagnosis of injuries and also people that have pain. They need treatment for pain. Thankfully, a couple of years ago, she was introduced to Dr. Brad Sorosky and Dr. Susan Sorosky of the Desert Spine Sports Physicians. And they actually have an office really close by from here. And they already came in with a huge respect. And when she got to know them and we received feedback from our patients that we had sent to them, their respect had grown exponentially during that time. And since then, we have obviously confidently sent patients over there and referrals. And I recently met with Dr. Sorosky and was very impressed by who they are, the type of program they have, the type of practice they have. So to better understand where they are coming from, we want to share a couple of quotes from them. And I love these quotes. The first one is from Dr. Brad Sorosky. He said, "I focus not only on taking care of the patient's pain, but rehabilitating beyond the resolution of symptoms to prevent future recurrence and facilitate an active, healthy lifestyle." Now, that sounds just like us here. We want to facilitate the best healthy lifestyle, and that's in his philosophy. Dr. Susan Sorosky said this, and I love this first line. I wish I would have come up with it. Don't live your life on the sidelines. That's awesome. Don't live your life on the sidelines, she says. My philosophy is to develop individualized and comprehensive treatment programs, to facilitate recovery and furthermore, to prevent re-injury. So not just recovery, but looking at the long term. Remember, we always talk about the long term. So it gives me great pleasure to welcome this medical power couple from Desert Spine Sports Physicians, Dr. Susan Sorosky and Dr. Brad Sorosky. Dr. Susan Sorosky and Dr. Brad Sorosky will be here in a minute. We lost a little bit of the recording, so I'm going to fill you in and catch you up. So Dr. Susan Sorosky first, she did her MD at the University of Texas Southwestern Medical School and also went to Yale University, which is very impressive. Her residency was done at the Physical Medicine and Rehabilitation Institute of Chicago, which is recognized as the best rehabilitation hospital in America. She's board certified. She has written research projects. She's written chapters in books, is what we're going to hear about later. And what they do there is, in her practice and what she does, along with Dr. Brad Sorosky's comprehensive musculoskeletal evaluations. So they're MDs that actually diagnose, and they're skilled and trained to do that. Now, and one interesting thing about her is she was a professional dancer, a professional ballerina. The ones that are on their toes, she was one of them. And Dr. Brad Sorosky, perennial top doc, did his MD at the University of Texas Southwestern Medical School. That's where those two met. And he went to also the University of California at Los Angeles, went to the same residency together in Chicago, and he did a fellowship at the Rehabilitation Institute of Chicago. Board certified, has also done some publications and written chapters in books. And he also has a history of excellent work in physical medicine and rehabilitation, and is an expert in the field. The other thing I wanted to tell you about them is they're known as physiatrists. So physiatrists are the name of someone, an MD, that works in the area of physical medicine and rehabilitation. And they try to do things that will happen before surgery or to avoid the surgery, because 90% of musculoskeletal surgeries are unnecessary. It needs to be something else. So what they'll do is see somebody, do a diagnosis, and of course, if they need to go to an orthopedic surgeon, they send them there. And when it comes to physical therapists, comparing them to physical therapists do not diagnose injuries and so on, and don't look at the whole person. And so a expert in MD in physical medicine and rehabilitation, a physiatrist, would be doing that. And now it gives me great pleasure to hand it over so you can see the real Drs. Sorosky, Dr. Susan Sorosky, and Dr. Brad Sorosky. Take it away from where we're at.
A lot of different things with great generality. A orthopedic colleague would go to 5 years of residency to learn about the surgical management of a musculoskeletal issue, and very little time on the non-operative counterpart, which is really interesting and important because probably 90% of musculoskeletal injuries do not require surgery.
Can you say it again?
90% of musculoskeletal injuries do not require surgery.
Wow, that's huge.
So in going to a surgical specialist, obviously that person would have more of a impact in talking about surgical remedies for that, and maybe not as much in terms of non-operative.
Got it. And it's not like they're bad doctors or whatever. It's just that's the way that their training is. And that's,
our closest friends are orthopedic surgeons.
Yeah.
And a big part of our practice is knowing, what can we take care of, and then what do we have to refer on to surgery. And there's a lot of indications. Patients will come in and right away will say, no, this needs to be managed surgically, and messing around with conservative care could actually put you in a worse situation.
So that is so important, because obviously the philosophy here is minimizing, invasiveness, but you're not keeping people in there just to drag them on as long as you can. But if you identify them as needing surgery, that you're gonna.
Yeah, it's almost a bit of a triage. If
someone
comes in with a herniated disc, do they have a foot drop? Do they have a severe neurological weakness that's significant? That patient may be more apt to go to surgery, and we're able to facilitate a surgical referral very quickly to somebody that's tough in the field.
I love it. So Dr. Brad, to you, society is getting so much more sedentary,
right?
Especially with COVID, with the lockdowns, and you look at the amount of people using smartphones, computers, even before COVID. So have you seen any specific injuries or problems because of, using computers more and using, and being less sedentary because of that?
More sedentary. Yeah, I think COVID has accelerated that. A lot of these things we were seeing prior, with more and more cell phone usage and computer. We weren't designed to do this and drive our car and stress.
I got to go straight.
Yeah, exactly. And so, one of the things we call it texting neck is
texting neck.
Texting neck. Yeah. And so, if you think about it, as you start to lean forward here, gravity's pulling us down, and your head weighs a lot, and all the muscles in the neck and the upper back, they have to counterforce that so that your head doesn't fall.
Yeah.
And over time, that creates tension, that creates pain, and it can create even arthritic conditions. So postural alignment is so important, sitting up straight, which I'm not doing well either. And then on the flip side of that, motion is lotion, and our body's designed to move, right? And I'm sure the same thing holds true for cardiology. So, being more sedentary, working from home, sitting in chairs for long periods of time in front of a computer, not good. We actually see the most degeneration occur in individuals that are too sedentary, not in ones that are more active.
Got it.
That probably, sometimes we'll get into the pathophysiology of that with our patients as well. The discs, that allow for motion, the shock absorber, the spine. There's no blood flow there. So they don't heal, and they get their nutrition through loading and unloading through the vertebral end plate, and that's a process called imbibition. So
imbibition, write that down and impress your friends.
You got to move.
Imbibition.
And all this COVID thing, make it more sedentary. Plus, the gyms are shut down, so we got to be creative and continuing to exercise and focus on our well-being.
No, so that's really interesting. That you would think that the assumption would be people seeing you are the active ones that are doing this and doing that, but there's a lot of them that are seeing you that are, it's because they're not active.
No, absolutely. It's truly the epidemic of sitting, and epidemic of sitting and poor core strength, et cetera. Interesting other thing that happens with discs that we talk about is something called creep. So if you're sitting for a long time and not getting up and not moving around, the tissue of the disc, it's soft. It starts to deform and become a little bit too elastic. And then as a compensation to that, the muscles go crazy and they fire up and cause a lot of muscular pain. So not only are we deforming the disc and causing issues with that, we're also causing a lot of muscular pain in our patients.
Yeah.
So
that answers my next question. Actually, I was talking about lower back, and that answered that. So that was pretty good. So Dr. Susan wrote a chapter in a medical book. Congratulations. She may not remember that. I was in the archives looking at this book that was written. No. So it was the management of low back pain. So I can tell you that, first of all, congratulations on writing that. But can you tell us, are there any top 3 management tips you might have for low back, and any examples you might want to share with us? Because I think that's a hot topic for a lot of people, at least a lot of them that I see.
I think the 3, the biggest thing I say is the physical component. So core strengthening is the most important thing to do to control pain. And also lower extremity flexibility. And I see that in all people, including my husband. People like to exercise. Sorry, I'm a big yogi, so I'll just put that in there. But people like to exercise. People that exercise like to lift weights, they like to do cardiovascular, but stretching falls by the wayside in so many patients. So it's core, but it's also keeping your hips and hamstrings loose, whether that's on your own stretching or yoga. But that's important. So the physical component. And then the thing I always tell patients is to don't do the stupid stuff. And I mean, there's a little bit, and I'm not a restrictor by nature, but going into the gym with a disc problem and doing deadlifts or weighted squats, there's a few things that probably are not on the greatest list of activities. Yes.
Or in your backyard, lifting up a big stump.
The heavy, awkward things. And that's also in my list of stupid stuff. So lifting heavy, awkward furniture, helping people move, bags when you're traveling, those kind of things. And the last thing, and we were talking about this the other day, that's so important to talk about our patients with degenerative disc disease, but also other musculoskeletal dysfunctions, is adapting our exercise programs as we age. And certainly what we did when we were a teenager is really not appropriate for when we're 30 or 40 or 50. And it goes on. We have to constantly adapt what we're doing and listen to our bodies to be able to age well. We really have to look at that really importantly. And
how we address that, it doesn't mean you're wimping out or doing less. You're optimizing that type of activity or skill set you're doing to where you're at. So that's what you're talking about, and it's spot on. So Dr. Brad, as you know, our practice is all about the root cause. And it's the root cause of problems. It also can be, why are you getting better? So what are the root causes? What are you changing? But most of the time you look at root causes of problems. So I believe your practice has a similar philosophy. So, can you explain how you see the importance of root cause and how you work and how you might use an example of that?
Yeah. So, one of the things that I think separates us is we have to be very specific on what the problem is. And the more specific we are, the better chance we have of being effective in the treatment plan. Saying someone has knee pain or back pain or neck pain, that's not specific enough. If you're looking at the knee, for an example, right? The first thing that we kind of process our mind is, what's the pain generator? Is it the articular cartilage that's wearing away? Is it the meniscus? Is it torn ACL or MCL, which are ligaments? So that's a pain generator. Then, why do they have these things? With the knee, obesity is an issue. For when you walk, 4 times your body weight is transmitted in forces through your knee. So you lose 5 pounds, that's 20 pounds less of force through your knee.
Wow.
So you don't have to lose 50 pounds, just small increments can make a huge difference, right? So that's someone with arthritis. Or, in my younger athletes, one of the things that's fun about what we do is we take care of young athletes to, people, in a more geriatric function, they're just trying to maintain mobility. And it's all kind of the same principle. But anyways, in a younger athlete, we're going to look at how do they load in that knee? How do they jump? How do they land? They may have weakness in their glute and in different planes of motion.
That's the buttocks, glute.
There's the glute, And if that knee is collapsing too much, they're going to be at higher risk for ACL ruptures, And so we try to look at pain generator, we try to look at biomechanics, and then come up with a plan to get them feeling better and then keep them out of trouble.
So I love hearing that, because it's not just, okay, you got knee pain, let's get rid of the knee pain.
Yeah.
That's not the way that you go about this. And we love that idea. And that's why our patients benefit from that, because it's not putting a Band-Aid on something because it's just going to come back worse. And like one of your quotes was, so it's not re-injured, so there's not a problem later on.
Well, I think we also talk about that as the kinetic chain a lot, right? So the ankle is connected to the knee, is connected to the hip, and it is all functioning as one whole unit.
So if somebody comes with a hip pain, it may...
Yeah, hips are fascinating. I mean, there's so many etiologies for hips, from the back, from the hip, from the knee. It's fascinating.
Got it. So you can't just focus just on the...
Well, and that's another thing. I mean, I was thinking about when you asked me to define PM&R and how that was different or unique as a medical specialty, is that we really focus on the whole entire system of musculoskeletal. So the whole person, the whole, not individual organ systems, but how it all functions together.
Well, so that sounds like Dr. Firemuck always says, wherever the vessels go, it's her domain. So you may be getting into physical medicine. No, I hope not. Okay, Dr. Brad, you also wrote a chapter in a book. And it was about something that I'm interested in, which is, I think it had some degenerative disc issues in it.
Yeah.
And as people get older, we're all concerned about that, I believe. Can you tell us, about that? Is there any way to prevent it, or is there any way to? What do you have to say to us about that?
Well, I think there's a lot of overlap with you all as well, because blood flow is important, and as I was alluding to earlier, the discs don't have a lot of blood flow, so being active, not doing the stupid stuff is really important. But genetics does play a huge role.
Okay.
And I don't know that we have genetic markers as established as you all have for some of the risk factors.
Mm-hmm.
But there was a study, the National Health System out of Sweden, where they looked at identical twins with discordant behaviors.
Okay.
And what that means is they share the same DNA, but they were different. One was maybe obese, one wasn't. These are the twins.
Yeah.
One smokes, one didn't. One did sedentary work, one did labor. And when you looked at their spines, they were remarkably similar. So based on some advanced mathematical modeling, they kind of were able to state that probably 70% of those degenerative changes were genetic, and 30% were more environmental. So it's a little depressing in that we can't control a lot of that. So what we really do is we try to focus on that 30%, what we can control, right? And that's probably true in all of life. Let's worry about what we have control over.
And you're absolutely right.
And the other part we can't do a lot about.
And that's what we talk about in here, is where you try to, you tamp down the bad genes as best you can with all the positive things that you can do. So don't let them express so much. Just get those positive things that you have control over that take maybe a little bit more weight on how you end up. So another hot topic, I'm going to go back to you again, Dr. Brad, is the degenerative therapies. Regenerative therapies, when people have degeneration or they have injuries. That's a very hot topic. So what's like some research on that? I get these questions and I can't answer them.
Yeah, so I think there's a difference between hope and hype, and that's, we all want to stay young. We all want to continue to do everything we want to do. That's not always a reality. We're going to do the best we can, and we can always improve upon our physical being. But, some of the things that are out there these days, I'm afraid, is more hype than reality. When it comes to stem cells, they've made some incredible advances in managing mostly blood disorders, leukemias, and multiple myeloma with bone marrow transplants, right? And these work. But then I think some more dubious claims have been made, that these same sort of stem cell treatments can be applied to arthritic conditions and tendon conditions. And some of these claims and practices are really running on the edge of legality if you look at it. And actually, in the paper just yesterday, there's a state senator out of Missouri that's a physician that's in huge amount of trouble for claiming that she was injecting these amniotic products that are kind of popular on the market, and saying that there were stem cells in there, and there's not. There's no viable stem cells in these amniotic products, and the FDA has been very clear about trying to put an end to some of these claims. So that's the depressing part. But there is some hope out there, and there is some good data on some other treatments. We're big fans of PRP.
Okay, explain that.
Yeah, which stands for platelet-rich plasma therapy. So what we do is we take about 50 or 60 cc's of blood, just out of a vein. We spin it a couple of times in a high-power centrifuge, and we take out the platelet-rich portion of the blood, which has been determined to help with healing of damaged tissue. And then we inject that into arthritic joints or into torn or partially torn tendons or ligaments. And the data is very encouraging. It's not a cure-all.
Got it.
Okay, we're not going to restore an arthritic knee, but for mild to moderate arthritis, the data is extremely favorable. In fact, There's another procedure you guys may be familiar with, Viscosupplementation, where they inject gel into knees.
Yes.
Yeah, Synvisc.
Mm-hmm.
Our last literature search, there was 5 studies comparing PRP to viscosupplementation. Every study showed that the PRP was superior.
Oh, wow.
So, there is data. That's back to the evidence-based medicine, really important.
Yeah.
Anecdotal, we make mistakes. And so PRP, I think, is a treatment that's here to stay. And there needs to be more research on this stem cell side of things. And maybe one day it's a lot more complicated than I think people understand. It's not just about injecting these cells in first where to get the cells. There's a lot of messengers, and it's a complex system to tell those stem cells to do what we want them to do.
Got it.
Yeah.
No, that's really interesting. And so what would you tell a patient who is interested in that? What should they do? Because if you go online, I mean...
Oh, exactly.
Show me the data, right?
Yeah.
I think that patients should be really interested, as they probably are in this practice, is what does the evidence show?
Yeah.
What does the science show? And certainly, some physicians are on the cutting edge doing things that aren't quite there yet, and I applaud them. We are not. We are very evidence-based medicine in our approach. And also being realistic. For example, PRP is not going to be the end-all for an end-stage arthritic knee. You need a little bit of cartilage in the joint to be realistic with expectations.
So the sooner you find, sooner you may have these issues is better for something like that?
Oh, for sure. Yeah. For all of what we do, the sooner we get to someone, the better.
So the patient that says, I'd say, how long have you been having that? Oh, for like 7 or 8 years. It just keeps getting worse. Well, before that gets to that, go get it checked out and have something done with it.
Well, and also the studies, at least for PRP, they're not existent for the back yet. So we're not doing any regenerative medicine at this point yet for the back. There are some peripheral joints near the spine that we are thinking about, but we're talking about mostly peripheral knees and hips and shoulder tendons, gluteal tendons, those kind of things.
But, I actually just did a search recently just to see what my patients would see when they do it. And, I think it's easier and easier to separate, what's real and what's not. When you look at the sources, if you go to a reputable institution, the Cleveland Clinic or Mayo, they have literature out there that's saying the same thing I'm telling you right now.
Got it.
When you go to an individual practice website or a blog, those are the ones where you need to be a little more careful on some of the claims that are being made.
And that's very good advice. So this has been great, and time just absolutely flew. So if somebody is interested in getting a hold of you or meeting one of you or one of your doctors, I know your doctors are all wonderfully trained. So what do they do? Go online? Do they call you? Do they come to us? What should they do?
Well, we have a great website.
You do have a great website.
DesertSpineandSports.com, and there's a...
She designed it.
Oh, did you? It's really, really good.
And there's a contact us option through there, or you can call us directly, and anybody in our front office can handle checking insurance and getting people scheduled. And we're all well trained in doing what we do. We've grown really slowly with what we call what we've talked about as our fellows. So these are people that we've trained over a period of a year's time, and we've grown very, very slowly with these people who all deliver the same message. We're all doing what we do.
To piggyback on that, we joined a practice when we first came to town, and there were different specialties, different training, and we kind of marketed it that it was nice because it was multidisciplinary. But the reality is who you got depended very much what kind of care you got. And our practice is modeled very differently. All the providers, we're all on the same page, very much so. Our PAs spend 3 to 6 months shadowing us before they see a patient and all independently. So we take patient care very serious. That's the most important thing. And our phone number is 602-840-0681. So if you're not good with a computer, 602-840-0681. And again, if you can't get in with Susan or I because our schedule's too busy, I promise you'll be happy with our partners.
And we have a lot of their information here, their business cards and some flyers. So when you come in next and you want to grab one or you're driving by, you can grab one. They're not that far from here. So I want to say this has just been wonderful. It's been wonderful meeting you both. And it's what's most exciting and wonderful is how you treat our parents. Well, she hasn't talked about parents yet, but how she treats our patients. I mean, you guys both treat our patients so wonderfully, and they come back and they say that. So thank you so much for treating the people that we really care about the most as our member patients.
We're honored to treat your
patients. Yeah, thank you.
Thank you so much.
Thank you.